Okay. Good afternoon, all. I, Dr. Siddhi, on behalf of NHSRC and DPSRU, welcomes you all for the 24th session of STG lecture. Today's session is on challenges and management of TB. I welcome our Executive Director, Dr. Major General Professor Atul Kotwal, sir, Dr. Deepika Sharma, ma'am, Lead Consultant QPS, Rajendra Prasad, sir, and our Sangeeta, ma'am. I request Dr. Deepika, ma'am, to welcome the participants and share the objectives of the session. Over to you, ma'am.
Thank you, Siddhi, and a very good afternoon and welcome in 24th series of the National Health System Resource Center and DSRUD STG series. And it's my pleasure to introduce our chief guest, Major General Professor Atul Kotwal, sir, SM, VSM. And sir is a medical professional and public health researcher, as well as ED NHRC. Sir has more than 150 publications in Index Journal, and he has immensely contributed in evidence generation and knowledge sharing in public health. And sir has supported and guided us to complete this 24th session of the standard treatment guideline, and we hope that we will continue this series next year also. I also welcome Dr. Rajendra Prasad, Director, Medical Education, Professor and Head Pulmonary Medicine, IRA Lucknow Medical College, and sir is also the chairperson for the National Task Force for TB Elimination Program, India. And we are fortunate that sir will talk about management of TB today. We also welcome Dr. Sangeeta Sharma, Professor Head Neuro Psychopharmacology, IBHAS, and President of DSRP PUD. And we are grateful for the ma'am for her relentless effort to continue this series. Today's session is of great importance to the public health professionals as well as the specialist doctor, program manager who have joined us. Without taking much of the time, I invite Atul sir to address the audience. Welcome, sir.
Thank you. Thank you, Dr. Deepika. Good afternoon, everyone. I hope I'm audible.
Yes, sir.
Okay, thank you. Yeah, good afternoon, Dr. Rajendra Prasad. From IRA Medical College. IRA always reminds me of Dr. V.K. Srivastav, whom you would be definitely knowing very well. He is a great teacher and mentor. And Dr. Sangeeta Sharma, as Dr. Deepika rightly mentioned, your incessant, work to and approach towards SDGs and the implementation. And I must, commend your efforts toward these activities, which are very much required. So today's topic is, I think, very, very important because tuberculosis is the disease of antiquity and still one of the world's deadliest diseases, although it's both preventable and curable. When I joined my MD medicine in 1989, I remember reading a journal in the very first month of joining the MD that TB will be addressed only when people like us, those reading that particular journal, start getting affected by TB. That was in the year 89, and but then we have come a long way since then. But even then, we know that every year 10 million people globally fall ill with TB, and it's no more a disease of, of course, we say there are a lot of social determinants of health, but now because of the increased communication, increased interactions, and we all know all of us, all our healthcare workers. Good to see 144 participants on a Saturday afternoon. I just checked the number of participants, become 145 now. So all of us know the mode of transmission, the types of TB. I'm not going into details. Plus, two experts will be talking to you about that. But India has the highest burden, which we all must know, with an estimated 3 million cases and 2 million new cases every year. And there are 2 deaths occurring every 3 minutes from TB. That's a huge number. But all of these are preventable with proper care and treatment. And Government of India, if you just have a quick recap and recollect that the Government of India launched the National TB program in 1962, and District TB Center was the the model which was involved. And Dr. D. Banerjee, I don't know, we have a lot of people here would not have heard of him, but he was the one, and subsequently he published a book also. And I have had the honor of being taught by him when I was in JNU for 1.5 years doing my postdoctoral fellowship in epidemiology. He was a professor emeritus. That the the mass miniature X-ray and all other things failed, and he rightly said and showed it and proved it also that it was symptoms and subsequent care and treatment which can solve the TB problem. But somehow we have not been able to succeed till now. But then in 2017, the National Strategic Plan which came up, that is now a ray of hope, which you all know that realizing that we won't be able to meet the targets in 2022, we had the revised NSP 2025, which identifies a number of goals which still need to be carried out for elimination of TB from India. That's in the SDG goals mentioned by 2030, but we have committed ourselves for elimination by 2025. And the actions which are recommended, for which all healthcare workers, all of us present online, need to act on this. That one is the TB elimination campaign, inspired by the goals and the lessons which was learned by the polio eradication program. That's the kind of the approach which is there, very focused, and the reinforcements to the existing workforce. So we all know we have a CHO also now at the sub-center level to provide that kind of the initial screening and investigation and referrals and all, and subsequently follow up. We have ASHAs and ANM definitely which are following up, and also MOs and specialists at various levels, and staff nurses in between. So all of your role is very important. Provider engagement, the private provider engagement, which is scaled up, they also get some kind of finances also linked with that, and from passive community involvement to full community participant and ownership. And that's where the involvement of village health sanitation nutrition committees, the Jan Arogya Samitis, Mahila Arogya Samitis, self-help groups, the Rohi Kalyan Samitis at the CHC and DH level become very important for all of us to involve them in all activities, including tuberculosis. And investment in TB surveillance staff and system for accurate, complete and timely information. Under PMO funds and Finance Commission funds which are supplemented the NHM funds, we all know there's a network of labs being created at the block level and district level, integrated district public health lab, block public health unit with the lab also, and sample transport systems which are now being established in various states. And a number of tests which are available at sub-center and PHC and CHC. Once all that in place, and we start using the integrated health information in portal IHIP, linked with the LIMS lab information management systems, this kind of surveillance systems will become very effective and efficient, which will tell us where any case is happening, and then of course follow up the close contacts also. And we have preventive therapy also now, which is coming up. New precision diagnostic tools. That's again, even though there will be certain diagnostic dilemmas, I'm sure both the experts will try to cover a little bit of that. But we are improving with those newer and newer tools, and those are now available at the peripheral level. And even if something is not available below district level, the sample transport systems are, as I mentioned earlier, are being strengthened so that the sample reaches there. And then supporting patients through the treatment. So Nikshay Poshan Yojana, we all know. And we also know the Nikshay Mitra Yojana, and also a lot of self-help groups and NGOs and all are providing and the meals and all, diet and all for the tuberculosis patient in the healthcare facility. And of course, the promulgative part of view, redesign and pursue targeted active case finding. That has to continue as such. Passive case finding is not the solution. The active case finding, and also the contacts and the close contacts need to be looked at. Overall socioeconomic development to address social determinants of health, which you all know, our GDP is increasing. A lot of people are coming out of poverty. That takes time, but that is also another determinant which is very important, which is taking place on its own. But as far as our role is concerned, as I listed few of these, we have to be very proactive in this. And of course, deploy and evaluate ambitious plans to implement the TB preventive therapy, which I mentioned earlier, in households, to other close contacts, children, people living with HIV, and other locally defined, high-risk groups, and with using new and short regimes which are available now. So the four basic blocks, if we see the approach for National Tuberculosis Elimination Program now, is detect, treat, prevent, and build. So these four, our role is in detection, our role is in treatment, our role is in prevention, and of course the policies and all which are there. Once we give inputs, the policies, of course, the flow from that. I'm not going into details of the elimination program and all also, but it's a multidisciplinary, multi-speciality, multi-sectoral, multimodal approach involving everyone. All the healthcare workers, starting from the most peripheral level to the specialist, super specialists, in between everyone. and the policymakers, administrators, and of course the community. We should not forget that. Without their involvement, we should not be able to address this issue. So that's why today, in this entire series, today we are focusing on this important healthcare problem, the challenges and management in today's lecture series. Dr. Sangeeta Sharma, and then management by Dr. Rajendra Prasad, who's Director of Medical Education and Prof in Pulmonary Medicine, IRAS, Lucknow Medical College, and Vice Chairman also of the National TB Elimination India Task Force for National TB Elimination India. So I'm happy to see 151 participants now on a Saturday afternoon, and wish you all happy learnings, and looking forward to your inputs on this, and also your suggestions for further topics which we, along with this group, will organize subsequently. Thank you very much, and wish you all the very best. Thank you.
Thank you so much, sir. Now I request Dr. Rajendra Prasad, sir, to start with the session. Dr. Rajendra is Director VP Chest Institute, University of Delhi, Director of UP Rural Institute of Medical Science and Research, and Head of Pulmonary Medicine, KJMC, Lucknow. He is International Governor of the American College of Chest Physician, USA, Vice Chair, National Task Force, NTEP, India, and President of 5 major associations in chest medicine. He has authored 12 books, including 4 on tuberculosis and at least on fiber optic bronchoscopy based on Indian patients. He has published original articles, reviews, and book chapters. Also, he has supervised more than 215 researches and theses. Sir has received Dr. B.C. Roy National Award for Developing Pulmonary Medicine in India 2016. Lifetime Achievement Award for National College of Chest Physician, India, Indian Chest Society, Tuberculosis Association of India, Thoracic Endoscopic Society of India, and Indian Association of Bronchology. Sir has also received many more awards. Over to you, sir. Sir, you are muted.
Thank you, Dr. Siddhi, for a very elaborate introduction, I must say. And thank you, Dr. Sangeeta Sharma, for inviting me for this small talk on tuberculosis. And then the role has been, the ball has been already set rolling by Dr. Atul Kotwal, who told you to my understanding, the gist of National TB Elimination Program, how it is going and how we should go ahead to end TB from this country by 2025, as per dreams of our Prime Minister, Sri Modi ji. So, Atul Kotwal has also reminded me, one of my senior and my good friend, late Dr. V.K. Srivastava, who is no more. We were together in KGMC for a very long years, and I had a great association with Dr. V.K. Srivastava. So with these few words, let me share my slides, and share is this. So when I say share, so my slides are visible, I hope.
Yes, sir, your slides are visible.
So I'll skip some of the slides. You know, I usually start my presentation by a Japanese proverb, which I learned when I was in Japan way back in '89, that better than 1,000 days of diligent study is one day with a great teacher. So that these words are very, they are good for my mentors, at least. My mentors mostly from KG, and then even the national mentors like Professor P.N. Tandon, who has been governing body chairman at Vallabhbhai Patel Chest Institute when I was a director there. And then Professor Hari Gautam, who has been our vice chancellor, and then Professor Ganguly, who has been associated in many many studies, and my own teachers like Professor Khanna, Agnotri Saab, Jafar Jamil, Jiten Nath, and Dr. Mukherjee. So they are all my own teachers. I've been mentored by them. And if I reminded to you by my Professor V.K. Khanna, he was one of the leading stalwart in tuberculosis. And he used to talk to me in my undergraduate days. I'm reminding my 74 how to manage drug-resistant TB. That time, even drug-resistant TB and MDR TB names were not there. But whatever basic principles he told us in the MBBS final year classes, to me it still remains true. So that tells the depth of my mentor, Professor V.K. Khanna. So I pay tribute to him. He's no more. And these are my institute where I have been associated. This is the King George Medical University. When we studied, it was college, then become university. Then this was the SAFI where I has become director for. And then Patel Chess, finally I joined here, and currently I'm working in Era Medical College. I will be quickly talking major issues in diagnosis and treatment very briefly. I'll touch upon those. And so what is, when I talk about tuberculosis, I always say, you see one of the example, this man who was young, started with cavity and a lot of infiltrative lesions, sputum was positive, and when he was treated, it was in 1998, it was the era of revised National TB Control Program. KGMC was the first dot center in medical college. We have this facility there in 98. Those days, intermittent regimens were there. And even with those intermittent regimen, patient got well, and I know that he is still all right. That is a story of a drug-sensitive tuberculosis. I still remember a young 17-year-old girl who came to me from Muscat when I was in KGMC. After taking about 4 or 5 primary line drugs for 1 year, her sputum was still positive. It means, and you can see the X-ray also, this was 1 year before and this is 1 year after. The lesion has extended. Initially the lesions were less, and then it has increased. And then sputum for AB was, those days gene expert, these molecular diagnostics were not available in India. However, we get culture and sensitivity, and we could prove that culture and sensitivity could prove that C is a pre-XDR TB, means along with the rifampicin resistance, she has also resistance to fluoroquinolones. So on those days, what was the regimen for MDR TB? I can remind you, in 15-16, kanamycin for 6 to 8 months, ofloxacin, and so we gave him kanamycin for 9 months. Can you remember, young lady? And I used to say their parents that if she want to live, she has to complete the therapy. And the drugs like ethionamide, cycloserine, moxifloxacin, pyrazinamide, ethambutol, this is the regimen at that time in vogue, and we treated her. And after about 2 years of treatment, that was the duration in those days. And you can see that the lesion in 16 and lesion is subsequently started reducing. She has started converting sputum, and ultimately she became culture negative, and she got well. Now I know that even in 2018. So after 2 years of the stopping the therapy, still she was well. and she is still in my follow-up. Now she is married, had a children. So what I'm trying to say with these two, one drug sensitive and one representative drug resistant to the extent of pre-XDR TB, if you manage tuberculosis well, what I'm trying to say that I always start with these two, that tuberculosis is almost curable disease, almost curable. I say 100%. This I'm not saying from book, although it's written in the book, but maybe at least myself has treated lakhs and lakhs of patients of tuberculosis in last 45, more than 45 years. So almost curable, provided adequate treatment is prescribed. Adequate, mind it, word is adequate. And it is not only the prescription of the treatment, the patient should also complete that regimen. You know, the young lady I refer to you, pre-XDR TB, every time parent used to ask me, sir, how many months of injection? I said, what literature is available at this time, minimum of 8 months of kanamycin. And I was able to convince their parent and her, and she has completed and she got with. That's why there are two if and buts. Treatment prescription should be adequate, and the patient also should be compliant. Patient will be compliant as per your advice. How you advise, how you counsel your patients. I'm just referring again that the second young lady, I have to spend more time on counseling rather than on writing the treatment. So that is why she completed the therapy. That is why she got 100% cure. So that's why I said it's a very curable disease, but it is very unfortunate, as Dr. Atul has also touched, about 3 lakh people died last year in this country from tuberculosis. This is the latest figure available. And then, I always pose a question, why this is happening? In the first 2 slides, I talked, yes, it is a curable disease, but then deaths I have shown you, and Dr. Atul has also touched large number of deaths. And why? Because only one, I can spend all 3-4 hours to explain you, but at least one of the major issue is a poor management of all patients who are there. They are not being adequately diagnosed. Although we have a program, we have everything, program has improved a lot, has involved large number of people, a large number of people are now attending. Still, many patients are outside the program. They are in the private sector. And how they are treating, that is also a big issue. And so poor management of TB patients, I can focus you to some of the examples. You know, this patient of TB was about, weight is about 68 kg. And you know, rifampicin dose is 450. This is inadequate dose. But this is a common prescription from the society. And this is another extra TB spine, you know, weight is again 58 kg. And this is a very common prescription for cost. This is very common prescription, what I see in day-to-day clinical. This is here also, although there are 4 drugs into it, but the dose is inadequate. So, like thing many I can share, I'll just, so this is the, preamble that TB, whenever one suspects, whenever it must be proven, must be, and if there is a tuberculosis, adequate treatment must be prescribed and must be counseled to complete that therapy. Then TB is curable. As far as diagnosis of TB is concerned, you know, a lot of changes has happened. One of the change I usually share that the definition wise, now if you see today patients of tuberculosis, I don't see any prescriptions, hardly any few prescriptions. There are only 2 types of, initially we used to talk sputum positive, sputum negative. Now those terms have been replaced. Microbiologically confirmed means person is confirmed either by phenotypic, say sputum for AFB, culture sensitive culture for MTB, are by molecular diagnostics, like gene expert, LPA, gene sequencing is now coming up by any method. So if you have confirmed the case by microbiologically, either phenotypic or genotypic, molecular diagnostics in general, they are known as genotypic tests. So if they are proven, then it is microbiologically. Otherwise, rest of the cases where they are not proven but you are treating, they are known as clinically diagnosed. Ideally, I want that in every prescription of the baby, and this is not only this. If microbiologically proven, then you have to naturally, if you are doing the gene expert within 90 minutes, within 1 day, you can find out whether it's a drug sensitive TB or drug resistant TB. What we call is universal DST. Every patient of tuberculosis we are treating. So that is the microbiology. I'll take you one example, simple example. Suppose somebody has a lymph node in the neck, and usual diagnostic to lymph node is the, you do fine needle, you just put a needle and take few cells out of that, and what is known as fine needle aspiration cytology, and by cells you decide, yes, it may be tubercular by seeing few cells, or by histopathology you see the TB granuloma. So it will, if it is not positive by, but these samples, if you have tested for AFB, if you have tested for gene expert, if they are positive, they will become same tuberculosis lymph node microbiologically proven. And if these samples are negative, only based on cytology or histology, you are diagnosing tubercular lymphadenitis, then it will be clinically diagnosed. That thing, this change has happened in about 2019 and 20, but still I do not see in the prescription of the private patients that. And then pulmonary, extrapulmonary is the same, and then even the history of ATT new case, recurrent, the relapse. So initially we used the word relapse. Now it has been replaced with the recurrent. Same word, same thing. Relapse means person who has been treated adequately and has been declared successful in previous treatment and gets the disease again. That was the definition of relapse. Definition remained the same, but the term has been, instead of relapse, now we are talking recurrent TB. Treatment after failure, the rest of the things remain the same. And you know, when you talk of a diagnosis, there are many diagnostic tools, starting from say X-ray, sputum, microscopy, molecular diagnostic, cytology, histology, and even drug susceptibility. DST can also be done through phenotypic method by culture, and sensitivity, or by genotypic method by gene expert, by LPA1 or LPA2, or even by gene sequencing now on a research basis being done, and very soon I think it is going to be introduced in the country. So these are the various diagnostic tools available to us. I'll just scan a few of the slides quickly. Chest X-ray radiology, though initially it has not played a much role in the TB control program or in TB elimination program today, but now it has playing a major role, because one thing you have to understand, it's a very sensitive test. Even the smallest or small lesion you can detect by radiology, chest X-ray, or even CT. But they are not specific. One cannot say very clearly that, yes, this shadow could be a tuberculosis. But still some of the things I always say which favors tuberculosis: pulmonary shadow, apical and posterior segment, if there's a cavity, miliary, pleural effusion, consolidation, high lower mediastinal. I mean, these are the things which might suggest that it may be tubercular. They cannot confirm. That's why I said this is a very sensitive test, but not a specific test. And smear, smear for AB, no doubt, is a specific test. Once you detect it, then the molecular diagnostics like CBNAT, or Gene Expert or TrueNAT, they are very advantageous for one reason, that one, the quickness is there. In 1 day time, usually now in the lab, 90 minutes it gives the result. And so you can get the whether MTB is positive or negative. And secondly, not only this, it also provides you the DST against rifampicin. So immediately on day one, if you see any patient, you may find out whether it is a drug sensitive or drug resistant TB. And if you do further test like LPA1, line probe assay 1, it further tells you, it first tells you the MTB is there, and it also tells you whether there is a rifampicin resistance is there or not, and it also tells you INH resistance. And there are 2 levels of INH resistance, high level or low level. So these all have some importance while you decide the treatment. And then this is the second line LPA, which talks about the fluoroquinolone resistance, which talks about the injectables. Although injectables are now not used, but second line LPA were because of the fluoroquinolone. So these Gene Expert, LPA1, LPA2 combined can tell you within a week's time, maximum within a week's time, whether a patient is a drug sensitive, patient is a drug resistant. If it is drug resistant, it is INH resistance, it is MDR, it is pre-XDR, or it is XDR type. Everything can be told. Now that's why the DST, drug susceptibility, universal DST, it has been made as universal DST. And the diagnostic algorithm, time will not, these slides I may share with Sangeeta ji, they may share with this, but has been, any patient comes to us, we do X-ray. If X-ray is suggestive, we do sputum. CBNAT is also done. So all the 3 tests are done in any patients of tuberculosis to detect that whether it is drug sensitive or drug resistant. And further, if it is drug resistant, there are a lot of other tests like first line LPA, second line LPA, culture and sensitivity. Everything is there in the program, in the private system, in everywhere, can use and can. Ultimate idea is to find out what type of, if it is drug sensitive TB or drug resistant TB, if it is drug resistant, what type of drug resistance. So all classification now is possible today, and tests are available in India in program free of cost. In a private sector, you have to pay for it. And I was talking about universal DST. So today, if I'm treating any patients of tuberculosis, universal DST is must. We should know in the beginning, are you treating a drug-sensitive tuberculosis? Are you treating a drug-resistant tuberculosis? Sometimes diagnosis is done by histopathology. I've already explained to you, by cytology, by histopathology. They're all clinically diagnosed, and many times when still we are not able to prove it, but we feel that it could be tuberculosis. Yes, you can provide empirical therapy. This rule has not been abolished, and once you but for empirical therapy, 2 very important things I always tell. One, that you have suspicion of tuberculosis. You should have presumption of tuberculosis. And then you have not been able to prove it out. And then third point, always I say, you must exclude other common possibility. And if there is no other possibility, then you can give anti-TB drugs. This is what is known as empirical ground. And once he response is usually not in a week and days and months time. It takes about 1 month, 1.5 months, 2 months. And if he responds, then in this situation, the treatment has to be completed. That is the empirical therapy. And gene sequencing, I'll skip. This is coming up. A lot of artificial intelligence are coming up. We are testing the artificial intelligence in chest X-ray. We are testing how the person is coughing. Those things are coming up very fast. And this is one of example, where I have shown you the first case with cavity. This young guy was also with the cavity, but there was a fluid level. Sputum for AFD 94 was negative. There's no gene expert at that time. And so if I say sputum is negative, I took the history. He was having high fever, cough with large amount of expect. Where is the tuberculosis? This was a pyogenic infection, has cavitated. So cavity not always means tuberculosis, though it is a common in tuberculosis. So we just gave him about 10 days of antibiotics. You can see how the cavity has disappeared. So that is why you have to, these are the few challenges I always face, that people are very quick to start anti-TB drugs. So take history, do physical examination, make your mindset whether it is tubercular or not. This is one of the examples. I can put you many others. So the two examples which are very confused with one is a pyogenic infection, another is malignancy. This guy Ramphal again has a cavity in here in the left upper zone. After 2 months of ATT, somebody prescribed, the cavity size has increased. So it can't be, it is either, if it is tuberculosis, it will be drug resistant or something else. So, and then finally, you got CT versus CT has typical characteristic of a malignant cavity. Eccentric cavitation, thick wall cavity, inner walls are very irregular. These are three textbook characteristic of a malignant cavity. So what I'm trying to say, cavity always not means tuberculosis. One case you have seen pyogenic infection, and this case is of proven bronchoscopy. When we did, we find growth there. So another very common challenge in tuberculosis is pleural effusion. This about 57-year-old lady was chronic smoker, had symptoms like cough, hemoptysis, and then it was diagnosed as pleural effusion initially, aspirated, given anti-TB drugs. When she received anti-TB drug for 3 to 4 months, the fluid and everything has extended. CT shows mass and fluid both, and bronchoscopy has shown growth here. So that is why what I'm trying to say, these are the usual differential diagnosis, either pyogenic or malignancy, whether it is pleural or parenchymal. So I always say to my students, whom I am taught for the last 45 years, that don't be dictated by any investigation. Take them with other details, history, physical examination, then try to think about the diagnosis. And next 10 minutes I will spend on very quickly how to treat tuberculosis today, if we are talking in 2024. So basic principles, nobody uses now single drug. Drugs are usually given in a single dose. That is, again, drugs are given in adequate doses and effective doses and adequate duration. These basic principles have to be adhered when you treat tuberculosis. And which drug to use? Drugs are available in separate pills as a FDC. Choice is FDC. But when you are prescribing FDC, in the government, it is FDC is being provided, because it is easy to consume. But with the FDC, one of the rider, I always say that it should be of good quality. So when you are prescribing anti-TB drug, you have not to compromise the quality of the drug, especially when you are using fixed dose. But usually, because even government accept that 6% of the drug samples tested as substandard in this country. Another standard, I always say that I have already that any patient, any doctor who is treating patient, it is his duty to make your patient compliant. That is very essential, and all the standards of TB care starting from 2006 to 2022, this standard always is talked. Monitoring is usually done by bacteriology is the best. Molecular diagnostics are not used for monitoring. Best monitoring method is bacteriology, sputum smear or culture. Radiology is next best. Clinical assessment also you should do. And ESR is, I don't think today in TB, nobody should write ESR. And at the end of the treatment, what we are doing actually, at the end of the treatment of pulmonary TB patients, certain sets of examination must be performed. That is what is we see one of the standards lately developed in 2022. And then and what are you must do X-ray at the end of treatment, microbiological, subjective, functional, even sometimes patient is dyspnea, you have to perform PFTs and other things and follow up. And each patient to set up a public, there are certain public health actions which are desired. One of the public health action is with TB notification, which is very essential. Contact investigation, Dr. Atul has already touched upon. The time will not permit me to say preventive treatment, but since preventive treatment has been introduced in India, so contact investigation, this is another duty of a doctor. If you are diagnosed any patients of tuberculosis, you should ask their close contacts and examine them. And if you find that there's TB, you treat them. If you find there's no TB, then you may provide the preventive treatment. That is what is contact investigation. Another new thing has come up. It is not that till you treat it for 6 months, then you forget the patient. Long-term follow-up now has been introduced. Although we are doing it as a clinician in a medical college for last 45 years, but now it is being in the program that every patient who completed the treatment, they must be followed up for next 2 years at 6, 12, 18, 24, at 6 months interval. That suppose if somebody relapses, somebody recurrence TB occurs, at least you should be able to detect it early. That is what are the basic issues in the treatment of tuberculosis. Now, treatment is very simple today. We have got two types of treatment, drug-sensitive TB and drug-resistant TB. How to treat drug-sensitive tuberculosis? This is the standard regimen today. 4 drug, rifampicin, INH, ethambutol, pyrazine for initial 2 months, and this is a daily regimen now. And then in a continuation phase, instead of 2 drugs, we are using 3 drugs, INH, rifampicin, and ethambutol. Total duration is 6 months. This is either he's a new case or he's a previously treated case but not registered. Initially, we have previously treated cases, 5 drug, a different regimen. Now we have got all new and previously treated patients. They must receive the same regimen. Previously treated must be drug sensitive, must not be a drug resistant. That is why then they will be categorized into drug sensitive tuberculosis. And even this period can be 6 to 9 months, can be extended in a situation like 3 to 6 months of intensive phase can be extended. Then treatment will become for 9 months or 1 year, especially in CNS TB, skeletal TB, disseminated TB. And in some of the situations, even steroids are also indicated. Usually fixed dose combination, dose was initially, now you can go, suppose somebody is 75 kg and above, and this is a 4 drug fixed dose combination having INH, rifampicin, pyrazinamide, ethambutol. One FDC contains about 150 milligram of rifampicin, and this is 6 tablet of rifampicin means 900 milligram. So now dose what we have been talking in our MBBS classes, 450, less than 50 kg, less more than 50, 600. Those rules have been broken now, and now you can depend on the dose. You can use the rifampicin much more. And FDC schedule has been there. Dose calculation is there. index TB guideline is for extrapulmonary tuberculosis. Luckily, I was also there when this regimen, this guideline was released, along with the Soumya Swaminathan and so many. He was DG, Dr. Jagdish Prasad was also there. And then many people are there I can recognize. Dr. Sareen was LRS director, and many WHO people were there. So then this guideline, and this guideline was ultimately, it's a blueprint has been prepared in 2023. And essentially the pulmonary extravasation, there's hardly any difference in only that sometimes you have to increase the duration and sometimes you have to use the steroids, especially in TB pericardium, pericardial effusion, TB meningitis. These two conditions where steroids are. Now that is about drug sensitive TB. What about drug resistant TB? Now I have told you we have many types of drug resistant TB. Drug sensitive TB, mono resistance means usually INH resistance. Then we have got MDR, multi-drug resistant tuberculosis, means resistance to INH and rifampicin. Then you have got XDR TB. Before XDR, you have got pre-XDR TB. Means when there is a rifampicin resistance plus fluoroquinolone resistance. And then we have XDR TB. XDR TB definition has now changed. Since injectables we are not using, XDR TB is first the MDR TB and then on the drug resistance to group A drug, which is being used for drug resistant TB. For drug resistant TB, the last guideline was updated in 2021, although there's a new guideline has come after that by WHO. India is considering that. I will touch in maybe a minute when we talk about future. And you know, now drugs are divided into 3 groups. You know, the lady I referred when I was treated, these were the drugs which are being used those days. But now, you know, the drugs were different. Group A means fluoroquinolones, levo, amoxicillin. Bedaquiline is a new drug. Linezolid is a repurposed drug. This is a group A. Group A drugs are best drug. Group B is clofazimine, which is again a repurposed drug for tuberculosis. It was used in leprosy. And then cycloserine is an old drug. So this is group 2. This is the best, next best, and the last best is the drugs what we used to use, like ethambutol. Delaminate is again a new drug. Pyrazinamide, imipenem, amikacin, though they are not prepared, ethionamide, and the PAS. This is how the classification today exists for anti-TB drugs to treat drug-resistant TB. And the regimen-wise, I'll not go into detail, but I'll touch that you know, all oral mono usually INH resistance. Initially we have no regimen for isoniazid resistance. Now we have regimen. It is 6 to 9 months of instead of those 4 drugs, INH, since it is resistant, so it was replaced by levofloxacin. This is not that when 4 drug you add leo. This is not. Here is INH resistance. There you have to use 4 drug instead of INH will be replaced. This is for total duration. This is nothing like intensive phase or continuation phase. Every drug is used. Then you have got MDR TB. MDR TB, now today we have 2 regimens. When I treated that lady in 2015, there was only 1 regimen, longer regimen, no shorter regimen. Now today we have a shorter regimen. That is a shorter regimen means again, initially it was injectable, now it is non-injectable. Bedaquiline is a drug, new drug I said, levofloxacin, ethionamide, clofazimine, pyrazinamide, high-dose INH, ethambutol, so large number of drugs. Shorter regimen is not for every MDR TB. It should be pure MDR TB. There should not be additional drug resistance. And then the next regimen for MDR is all oral longer regimen. When you know in all oral longer regimen, group 1 and group 2 drugs ideally have been combined together. Bedaquiline is group 1, levofloxacin is group 1, linezolid is group 1. Clofazimine is 2, group 2, and so all the group 1, 2. So 5 drug combination, and this is for 18 to 20 months. Time will not permit me to go into details. but then 18 months for MDR-TB and 20 months for XDR-TB. And the new regimen which is being tested in this country in many centers is a BPAL regimen. It's a good news. BPAL is the newer regimen for MDR and XDR-TB, and B is a betaculin, T is a pretomanid, a new drug again, and then linezolid, BPAL. So that is for 6 months. So you can understand what is going to happen in future. In 6 months' time, you can get rid of MDR and XDR. And in some India, it is being tested. In many parts of the world, it has been introduced. So, so sometimes you can think of surgery, and then I'll take another minute. What is going to be future of TB treatment? In future of TB treatment, if I say drug sensitive TB, drug sensitive, 6 months. We are trying hard for last so many years. Can we reduce this duration of 6 months to 4 months to 2 months? Yes, now studies are available. Even WHO 22 guideline of drug sensitive, they have advised this. Country is thinking about it. And now 4 months regimen is possible. Even in a recent studies, 2 to 3 months regimen is possible along with the newer drugs like betaculin. So I'll not go in detail, and this is all the published. And for MDR-TB, you have already seen that large number of trials are there, and even 10 to 22, this year we are talking of BPAL regimen, only 6 months for MDR. That is what is going to be future. And probably what I wrote an editorial way back in 2020. Are we moving towards development of universal drug regimen, treatment of tuberculosis? My hunch is, whatever science, little science I know, my hunch is yes, we are moving to, as we have moved to a universal DST, now we'll be moving towards universal treatment. When I say universal treatment, what do I mean? There could be one regimen or two regimen, or the same regimen can be used for drug sensitive TB. Now studies are on. Already they have some of them proven. And then for 3 months, drug sensitive TB, for MDR 6 months, for XDR 9 months. This is what is going to be a future of TB treatment. And so it's a universal regimen. I believe in my lifetime it is going to happen. And my last slides, take home messages has come. And take home messages, I always say, it's a better, you must have understood, it is better not to treat than to mild treat. If you have decided to treat, please treat with the full heart. And then you have, then if you are treating, then you should, diagnosis must be very clear, use most appropriate regimen, use drugs in a correct dose and duration, use quality medicine, that is another very important issue, where we'll see in prescriptions, use FDC or proven bioavailability, ensure regular intake, that is our duty. I always say, I always emphasize, do not experiment. If you are in doubt, please don't experiment in tuberculosis, otherwise you might kill. That is why you see 3 lakh people have died in India last year. So with this few words, my concluding, now you have got only hardly 3-4 regimen, one for drug sensitive, one for INH resistance, for MDR, we have shorter and longer regimen, and new regimen like BPAL. This is all 4 or 5 regimen is there. So with this, I would like to end my lecture. And before I should end, before I should thank to all of you, that even this lecture is on YouTube. Well, now people call me YouTuber also, because when I say if I'm in Lucknow, why in Lucknow? Why not whole India? So we have many YouTube lectures, and even this lecture is there on the YouTube. We have put lecture on history taking by demand of our PG students. And we have physical examination, auscultation, which is not very explained today. And then we have a very recent one lecture on X-ray, which has been seen by more than 3.5 lakh people. And then we have recently brought a book on chest X-ray. It was released this year. It is in 2 volumes. What I what I mean taught in MBBS classes, those students have always demanded from me, sir, why not you coming out with those X-rays from which you used to teach us? So with those X-rays, we have made this X-ray in 2 volumes, and you may be benefited. Is available in everywhere. And then we have many books on tuberculosis. I'll not say, and then I'll end before that doctor is a student till his death. When he fails to be a student, he dies. So please, we are in the profession until unless we keep learning. What I was told in 70s, 80s, if I tell that thing, you will say that what Dr. Prasad is telling. So you have to be reading, you have to be studying, you have to knowing what are the changes that happen. That's why anyone who keeps learning, that is another advantage of keeps learning, that we stays young. This is a very famous quote said by Henry Ford. And then finally, I say thank you very much. And in thank you slide, people like me that I am still learning. That is the point. Without learning in medical science, I don't think you are going to thrive. With this, I must thank Dr. Sangeeta and his entire team and team that for really asking me. I was a little sick about 3 days back, but then she requested. We have a large association with her and her team for last so many years, so I could not refuse myself. I said I will come and I'll talk. Thank you very much, Dr. Sangeeta. Madam, you are.
Yes, yeah. In excitement, you forget to unmute yourself. Thank you very much, Dr. Rajendra Prasad. I think we could not have a better person to speak about TB. He's so passionate about TB and other chest diseases. I thought he would be the right, best person around to speak about this. And he was not well, but yet he agreed and came today to speak to you. We could you could have made out his voice. He was, but still that's you can admire his passion for teaching, and you have seen the resources that he has created for future generations. All of these are worth reading. We would suggest you, this session will also be on YouTube. You can go through that and access these resources. I know he has to go for another commitment, but sir, can you take a few questions?
Yes, definitely, madam.
Yeah, you can write your questions in the chat box for him. I think things are very clear. He, clarified all of those very clearly. But yet, if you have some questions, you can write. And if you find that there are certain difficulties that you face during day-to-day management, you can ask him.
I'll also like to, come in for a moment. Thank you, Dr. Rajendra Prasad sir, for that excellent comprehensive talk. I had some other work and all which I was doing, but then I stopped at moment you started from your second slide onwards, and I learned and I heard the entire talk. Thank you very much for this. I'm sure all the participants, which include specialists, medical officers, staff nurses, even CHOs and all, would have definitely, benefited from this. Thank you. Thank you very much.
Thank you, Atul. Thank you, Atul Kotwal sir.
One thing that professors do very well is that they make it simple. I think it was, simple, but yet comprehensive talk. He touched on all aspects, and the bottom line, what is the most important? I think we are all dealing with the overdiagnosis, underdiagnosis, variations in the treatment. Unfortunately, those variations are still found despite having a TB control program for many decades in the country. I think there is one question about role of IGRA.
I mean, IGRA are another in our time, and still the Mantoux test, the tuberculin test, they are the same. It talks about only the presence of infection with Mycobacterium tuberculosis. still any test has not come which clearly tells that whether this infection has converted into disease or not. So this is only role is to just to find out whether person is, although in the preventive therapy, it has a great role because we wanted to know whether person has been infected or not. But then as a clinician, it hardly plays any role. But what I have experienced based on IGRA, based on tuberculin test, many of us, they start anti-TB drug. That is not a right process. Even, Mantoux test may be positive, IGRA may be positive. It suggests that person is infected. Then we have to search the site. Where is the disease? Until unless you are convinced, yes, that disease is there, you are not going to treat based on IGRA. That's very clear and very simple.
This is not for diagnosis purpose.
Yes, this is for diagnosis of infection. This is not the diagnosis of disease.
So you must rule out active disease first.
Yes.
And it is just indicates, and for latent TB, this is what we call latent TB. And if the patient falls in those categories, high risk categories, or household contacts of active TB or microbiologically confirmed TB, they would need to be put on TB preventer therapy. Sir, many times we have seen that AFB test is done, and if it turns out to be negative, we repeat it. Is there any change in the guidance regarding, should you repeat it, get the AFB repeated? Earlier, we used to get 3, AFB sputum test.
Yes, I think question is very interesting. AFB, sputum or any other secretion for AFB, if it is negative, can be repeated. There is no hard and fast rule. But today I said in the diagnosis, apart from these are the phenotypic method. Bacteria you demonstrate. But then the genotypic method should also have to be done in every case. If you suppose you suspect a TB, you get a chest X-ray, you got some lesion, suspected lesion, you got a sputum for AFB. Same day you also get a gene expert done. Advantage of gene expert that it will be more positive, more sensitive than sputum for AFB. And the second biggest advantage, it gives you the universal DST. It gives you whether person is a drug sensitive TB or drug resistant TB day one. That's why in every patient when I talked about diagnostic algorithm, that X-ray, sputum smear or any secretion smear, and then gene expert from the same secretion. This will give you the final result.
AFB negative does not rule out TB.
No, never. Yeah. Even gene expert negative does not rule out TB.
Yeah, I was coming to that. One gene expert test has come negative. What should be the next step?
Next step, of course, you have to. Okay. If gene expert test has come negative, there is no fun to repeat it. Usually it is not done because this is a costly test in a private sector. In a government sector, it is free test. But then you have to search for, you have got other parameters with you. And if you suspect that he's a gene expert negative, his sputum smear negative, and still he has some lesion in the chest X-ray, and you suspect, you can label him as a clinically diagnosed. Initially, we called it as a sputum negative pulmonary tuberculosis. Now we can diagnose as clinically diagnosed tuberculosis, and you are justified to treat such type of patients.
So what would be the role of LPA culture here in such patients where it was sputum negative, gene expert negative? So would we get something if we
yes, definitely. If you compare between sputum smear and culture, culture is a better test, more sensitive test, right? That is one. And so suppose smear is negative, still you are suspecting and you want to confirm, yes, you can go for culture. A culture, disadvantage of culture is, in spite though I have liquid culture now today, but still it takes 4 to 5 weeks to get the result. So it is time consuming, it is costly also. But culture is still in among all the diagnostics criteria. Culture is today, even today, it is a gold standard to diagnose tuberculosis.
Sir, would it be then right, for example, this sputum negative, gene expert negative, that you start and you strongly suspect TB here, and you start with ATT empirically, and meanwhile you wait for the culture report? Would that
Yes.
that approach be all right?
Yes, that approach will be all right if you have sent the culture, and even culture negative. If you have started the treatment and patient is responding, suppose and you find a culture negative, still you have to complete the therapy for betterment of the patient. That is one thing. And so the culture is not very commonly used test, although because of its cost, because of the time, so many factors. Not all the labs are doing the culture. Culture labs, always we said that it should be under quality control. We get a lot of bad results, poor results in cultures. So those things are there. So that you have to be taken care of.
Sir, somebody has asked, AFB positive and gene expert negative. Does it suggest non-tubercular mycobacteria?
Yes, it can suggest. One of the suggestion, if sputum smear is positive, gene expert negative, it could be not. But that can be proven only by doing a culture. NTM can be proven only by doing a culture. No other test can prove NTM.
There is a question on, is gene expert same as CB-NAT, TrueNAT?
Gene expert, CB-NAT, TrueNAT, they are the different names from different labs. So different generic name, I must say, but they are essentially the molecular diagnostics, and they talk about the MTV first. If you see any report, gene expert, CB-NAT, CB-NAT is another name of gene expert, but CB-NAT may have gene expert, may have TrueNAT also. TrueNAT is also a sort of a TV, and that tells two things: MTB plus or minus, and second, rifampicin resistance plus or minus. That is what it is implied.
What is the role of ADA in TB diagnosis?
ADA, in a pleural effusion or tuberculous meningitis, any of the serious TB, like pleural, like meningeal, like peritoneal effusion, if the cutoff value is more than 50 to 55, it suggests tuberculosis. It cannot confirm tuberculosis. That is one thing it should be made very clear. It is a suggestive of. This is not a confirmatory test for tuberculosis. Even we have seen ADA is positive in other diseases. Yes, suppose you just draw a fluid from pleura and you sign that it is exudative, lymphocytic predominant, ADA is more than 50, 55. Yes, you may think, yes, it could be a tuberculosis. But this can suggest this is not a confirmatory.
It can serve as a supportive role only,
yes,
not a
it has got always a supportive role.
Sir, here somebody has said they have a drug-sensitive TB pulmonary young patient, 28-year-old, who has been treated for third time since 2017. What could be the reason and future of treatment for him? There are no other comorbidities or complaints to treatment. Compliance to, I think he means compliance to treatment is there.
Yes, in such scenario, as you told, madam, proven drug-sensitive TB, prescribed adequate doses, has been compliant, is still not responding. I think that is the question, right? So in this scenario, sometimes, quality of the drug, sometimes the sub-therapeutic levels of the drug. So even drug level, in such situation, we advise that drug levels must be monitored, whether you are giving rifampicin adequate, whether it is really going into body or not. So these are the tests which are sometimes are advised, but they are the rare scenario. They are not very common scenario. But in rare scenario, you can advise a therapeutic drug monitoring.
Malabsorption could be one of the reasons.
Yes,
for
there are so many causes. Malabsorption, You know, HIV people, when they say HIV came, there's a lot of malabsorption in HIV. So such type of reactions, reactions are seen. So but these are the rare cases, but in this scenario, you have to individually investigate the patient, why he's not responding.
Adult BCG vaccination, is it useful?
Yes, lately, you know, the BCG vaccine in adults have been advised by Government of India based on many studies. What they have found that there could be an effective method because, you know, two things has happened, new thing in this country. One is the preventive therapy, which was very isolated, was there. Now preventive therapy has been made quite generalized. Second thing is the vaccine. Since we are not getting a good vaccine till date, we are in the process. The third point was BCG. Can BCG can help? So in initial studies, they found that the areas where they have revaccinated adult people, BCG, their chances of preventing the development of disease has been there. With this evidence, Government of India has started on a pilot project. Pilot kya on a country, not in every part of the country, but some of the states and some of the districts, and they are studying. This is being in a study mode, and they will find that how much help we can derive. But genesis was only to, since we are moving very fast to eliminate, to end the TB from India, so those things were required. That's why it has been introduced.
Sputum sample for AFB, should it be collected after food or first sputum in the morning?
Ideally, preference is first sputum in the morning, but for the sake of convenience, you may give any sputum sample.
Sir, there is one question about role of steroids in ileocecal tuberculosis.
That's a very important question. I usually take lecture on role of steroids in tuberculosis. But if I can summarize, in ileocecal tuberculosis, there is hardly any role of steroids in ileocecal tuberculosis. Steroids play a major role in, let me summarize again, I usually teach my students there are certain absolute indications of steroids where it is must. Like say, if you are seeing a patient of TB who is in the pre-terminal stages, who is dying, and you know that it is tuberculosis, extensive disease. So to buy some time, you know, anti-TB drugs will take time to work. So buy some time, you may initially prescribe few weeks of steroid along with adequate ATT. I have saved many patients with this indication. Although it is hardly written in the books, but this we have practically experienced, and this is very useful. Another indication of steroids are common indication, as I told you, in the paradox, in the TB of pericardium, pericardial effusion, that is very absolute. Tuberculous meningitis is very absolute. So these are three conditions, but then in situations like pleural effusion, especially if it is massive, peritoneal effusion if it is massive, and you can use steroids for some time, but whenever you use steroid, rule says that there must be adequate anti-TB coverage. That is the rule. Of alone steroids you cannot use it. Well, rare situations, somebody has talked about ileocecal. In rare situations, suppose I know that somebody has mediastinal lymph node, which is caseating, not responding with anti-TB drug. So there's a lot of inflammation, necrotic inflammation. In such situation, what as a clinician, I have used steroids, and I found in some of the patients is very effective. Drugs when they were not responding. So another indication of steroids may be the iris. Whenever many of the patients of tuberculosis, they have severe immune reconstitution syndrome, or you say paradoxical response, they are also in some situation we may use steroids in some cases. This is what my feeling about the steroids.
So how do we treat mixed infection with NTM and MTB?
There's hardly any mixed infection. NTM diagnosis is very difficult, and it has to be based on culture. Although newer tests are available, which talks about species, which talks about the drug susceptibility testing also of NTM, but NTM is not easy to treat. Your diagnosis has to be confirmed. One culture may not be sufficient. Probably you have to do 2 cultures, and then you may think if it is NTM, there are definite guidelines for all sorts of NTM. But I have not seen. Rarely I have seen a picture which is mixed. Either it is NTM or it is a pulmonary tuberculosis.
Sir, there is one question about complications of ATT and jaundice, I think, deranged LFT. How do you restart ATT?
That is a very important question again. And about 5 to 7% of the patient, when they are given drug sensitive or any treatment, they develop liver toxicity. And in liver, what is the rule says? Suppose I am treating, I have started anti-TB drug. Patient after 10 days, 15 days got loss of appetite. I see there is a jaundice, LFT is deranged. So LFT deranged to what extent? That is another question. Suppose the enzymes are deranged more than 5 times, increased. Serum bilirubin is increased. Patient is symptomatic. So in this scenario, you might have to stop all the therapy. And after you might have to stop all the therapy in a situation where TB is not very lethal. Suppose TB is lethal, then still you cannot stop all the drugs, so you can be only giving only hepatosafe drug. And best hepatosafe drugs are, although streptomycin is not used nowadays, but sometimes we have to use it. Then ethambutol is a very hepatosafe. Fluoroquinolones are also very hepatosafe. And even isoniazid, although the Western textbook make isoniazid a culprit for hepatotoxicity, but in India, what we have experienced, it is a very safe drug. In my 48 years of career, I have seen only 3 hepatotoxicity with isoniazid in this country. So what I usually say, suppose somebody has developed jaundice, you stop the therapy or don't stop, and after 7-10 days, you do LFT repeat. LFT suppose comes out to be normal, symptomatically patient improve. So you have to retry these drugs. Not that once he has developed that he will not retolerate again. So the sequence is usually what we do. We usually follow the British pattern. And in that pattern, what you have, first you start with the hepatosafe drug. Say you start with say INH, ethambutol, fluoroquinolone, depending upon the disease and scenario. And then if he tolerates INH hepatosafe drug, then you may retry first rifampicin. Rifampicin is many times they are tolerated again. And then if he has tolerated up to rifampicin, then you may not try pyrazinamide. Yes, if you want to take risk, you may try, but majority of people will recur. Jaundice will recur. So that is how. Another point which is to be taken. If you have not been able to use pyrazinamide in an initial treatment, then the regimen is not for 6 months. If you are using, say, INH, rifampicin and ethambutol, INH, ethambutol and rifampicin, this is minimum of 9 months duration. So those points has to be taken care of.
Sir, if LFT is deranged, let's say 3 times, but patient does not have any symptoms.
Yes, then you may continue the therapy and have a watch on the patient.
So by what time do you expect that LFT would return to normal?
Maybe 2 to 3 weeks time. You repeat it, 2 weeks minimum time you repeat it. And the patient is not symptomatic. Only there is a this is a known fact that there is a rise of transaminases in between during the treatment. And if he is not symptomatic, if follow up tolerating well, you need not to stop the therapy.
So when do you do repeat this LFT?
Maybe-
Should it be done
Maybe after 2 weeks.
straight away after 2 weeks, or some
Yes.
people say that you have to do it after every 3 to 5 days, or the book says so.
No, 3 to 5 days is advised when patient has developed jaundice and it is very
Symptomatic. Okay.
symptomatic and very extensive derangement of the LFTs, then you can do early. If it is patient is tolerating, why unnecessary you prick, and patient is not developing any symptom, you can 2 weeks time you can repeat it.
I think one more related problem is that many of the patients who are put on ATT, they don't tolerate, they vomit it out, because these drugs have to be given on empty stomach. So what advice do you give to your patients? I know it's time for you to go.
Most of the drugs they can create nausea and vomiting, and the common drug is rifampicin and pyrazinamide. Isoniazid and ethambutol, they are very tolerated even in this scenario. And so there, what you have to do, you give counseling, you give some antiemetic drug, some gastritis drug, and then most of the people, they tolerate. But suppose they are not tolerating, one thing I do, I usually do rifampicin after the meals, after the breakfast. Usually rifampicin is taken before breakfast. But what I have experienced that if somebody we can advise after the breakfast, the people can tolerate better.
Sir, one last question. I know you have to go. Why do we do culture of samples in pair?
Culture of samples in pair. I mean,
blood culture ka to suna tha, I heard of it, but I don't know about TB.
The culture is pair. I hardly have done anything, but the reason may be that suppose you are giving 2 samples, sometimes one sample is contaminated, so that you can get the simultaneous result.
I think thank you so much, Dr. Prasad, for such a beautiful explanation of these are the problems that people face commonly in their day-to-day practice. I hope you are all now clear about these things, and there would be better treatment outcomes when we ensure that the adequate treatment is given and compliance is assured for these patients. Thank you, sir.
Thank you, madam. I'm sorry I'll leave early because I have to move.
I think
one thing I always say that thank you once again very much, and whenever we have been associated for very long years, and you have seen my actually people say to me that you have passion for teaching. So anything if you require from me, you are most welcome. Thank you.
Yes, I know I can count on you anytime. I was not at all worried, when I heard about your illness, but I knew that you will somehow make it for today. Otherwise, had it been anyone else, I would have been a little jittery ki alternative arrangement karna hai mujhe. But with you, certainly I was very sure because he's so passionate, committed person, and I think you could also make out. Thank you, sir, for spending time.
So much, sir.
Okay. Okay. I think we'll continue the session. You've had, I think, after Dr. Prasad, I won't be able to add much to the session, but maybe I will quickly go through my session presentation quickly just to summarize some of these things so that take-home messages are clear about here. We know I will not go into the magnitude prevalence of this TB. We know TB is one of the top killers, and we have 1/5 of almost all cases of TB in our country. TB is now a notifiable disease in India because this has to be notifiable disease, because many people were not registering these cases, or they were not being treated properly. So now please remember that be it in private sector or public sector, everyone who is seeing these patients has to notify, and this has to be information has to be provided on the NHSRC platform for this. And NTB, we have missed the first deadline 2025, but certainly by 2030 we should be able to do this. Lot of efforts are being made to eliminate TB. And why are we talking about TB? Because we have 4 different forms that TB may exist. Almost everyone is infected, so we want to have this infection eliminated so that it does not get transmitted to other people. The transmission stops. And then we have latent TB infections, we have subclinical TB disease, and active TB disease. So there are a set of investigations, diagnostics available, and then we have the treatment available for each of these states. So it is important that we correctly identify these stages. And of course, the main aim of today's session was to bring a balance here, so that there is neither a underdiagnosis nor overdiagnosis, because both of them can be harmful for the patient. But certainly, if you are not sure, as if you recall, Dr. Prasad said, better not to start with ATT. Over treatment can lead to resistance here. So suspect, you all know about the symptoms of TB: fever, cough, if it stays for more than 2 weeks, weight loss. So all of these symptoms are suggestive of this. So there are 4 components to diagnosis of TB. One is microbiological diagnosis. We all have been doing traditional AFB. Then radiological X-ray chest is very important. Pathological diagnosis, if you have FNAC or infiltrates, that you do that. And of course, based on these, so based on all these 4, microbiological diagnosis is the most important. You can take this as a confirmed tuberculosis. So diagnostic confidence is highest with microbiological confirmation. You may have clinically confirmed tuberculosis. When used, all of these diagnostics used in combination can tell you the degree of confidence in the diagnosis. Clinical, radiological is there, and pathologically you are able to confirm it, or clinical or radiological evidence is there only. But there may be some situations when you have clinical diagnosis only, you are not able to substantiate this with any of these tests used to diagnose of TB. But all efforts should be made to get the microbiological confirmation and pathological confirmation as far as possible. Then routinely check all HIV patients and do fasting blood sugar, diabetic. Both of these patients may have atypical presentations. Now there is one more, practice that we observe is use of quinolones. These quinolones are used for treatment of pneumonia, but generally this should be kept as a reserve drug in an undiagnosed TB patient. So this patient could be of undiagnosed TB patient. So if you use quinolones, it can delay the diagnosis and can lead to development of drug resistance. So by and large, if you see community acquired pneumonia, quinolones should be avoided as far as possible. So that is why Indian guidelines do not support use of these fluoroquinolones, because also another reason is that these moxifloxacin and may be used for drug resistant TB as well. So whenever you have a patient of fever of unknown origin, or when a patient gives you a history of transient response of fever to quinolone, suspect that this patient may be having TB. Empirical fluoroquinolone prescriptions for pneumonia should be avoided. This is one message that I want to give, because there is a lot of misuse of this fluoroquinolones happening because they are used empirically for the treatment of community acquired pneumonia. Now we have a set of molecular methods for diagnosing tuberculosis: Gene Expert, MTP Expert, Ultra, TrueNat. All these things are now available. They are more, you can see that the turnaround time of these tests have decreased so much that you can have the report within 90 minutes. Same day you have reports coming from this. So all of these should be utilized in clinical practice. Just don't rely on AFB, because AFB negative does not rule out that the TB is not there. So, and if you look at the comparison of various diagnostic tests for diagnosis of TB, sensitivity of Gene Expert, Ultra is around 90%, Ultra is 98%, specificity is 98%. So must utilize these tests for diagnosing the patients with TB. So I'm again repeating, sputum microscopy negative does not rule out tuberculosis. So you need to do these Gene Expert test for this. So for diagnosis, get a sputum. For AFB smear, expert MTB, AFB culture as far as possible. Usually repeating AFB, although you can repeat it, but it's not desirable. Rather go for expert MTB test, so that you have a more sensitive and specific test available. Sputum AFB culture is usually not asked for, but it would be good if you can ask for it. It will help you in understanding the sensitivity pattern. Results are available within 2 weeks with rapid liquid media, so it is worth and especially AFB culture should be used if in the community, if you have INH resistance more than 1%, culture should be utilized. So you have standards for TB care in India. TB guidelines are there. We also have standard treatment guidelines. Recent edition was just launched in April, 7th edition. All of these things that we were talking about in today's session are dealt with here. You should refer to this. But unfortunately, even after having decades of these guidelines been there, we find that if you look at do the prescription audit for TB drugs, you will find all different kinds of regimen being prescribed. I don't know why, what is the reason behind it. When the treatment has been standardized, it is always better to use the standard regimen, because if you tamper with the disease, something like TB, we have seen that era, our age especially, it was all sensitive TB to first line. Then we saw MDR, now XDR, and we are moving to MDR TB. Although the research is going on, people are working on it, reducing the duration of the MDR TB as well. Now 6 months treatments are available. But remember that these drugs are toxic. They are costlier than the first line anti-tubercular drug. So it is very, very, very important that we adhere to the standard treatment guidelines. There was one question in the chat box about you should always use Gene Expert MTB test. This is a fully automated test and validated, standardized. can detect rifampicin resistance. Do not use these conventional PCR, TB PCRs, because these are non-automated tests, not validated, non-standardized, and cannot detect rifampicin resistance. So always use gene expert for that. Then you can that all these things are available. The turnaround time of these tests is very low, and the results are very good with these. True Not is nothing, but this is for Indian conditions. This is a initial test to diagnose TB and to sequentially detect rifampicin resistance. This is a battery operated system, works at wide range of temperatures, faster turnaround time of 30 to 40 minutes, but it needs training. 3 steps, 3 reagents are used, but it is working very well in Indian settings. I think I will skip this role of adenosine deaminase in the diagnosis. It is not a diagnostic test for TB. This can support your diagnosis, if that too, particularly when the levels are more than 70, then only there is a high likelihood of tuberculosis. If the levels are within 40 to 70, it may or may not be. So you may not be confirmed about this. So here clinical judgment would be needed, and certainly less than 40, you know that there would be less likelihood. But then in these patients, you must also consider malignancy, brucellosis, and Q fever, if that is also one of the causes of raised deaminase. Don't, one of the experts says, TB expert, don't do ADA, just do expert MTB. Decide clinically when expert MTB is negative. So standard regimen, as I said earlier, there are dosages, milligram per kg defined for this. Must use these doses only. You don't have to devise your own treatment regimen or own dosages. These are all standardized. Maximum doses also have been specified. Now, the doses in children, those also are given in the standard treatment guidelines. But in general, I also asked this question in the pre-test. Children need isoniazid little higher dose. 7 to 15 milligram per kg is the standard range that is prescribed, but usually 10 milligram per kg body weight is used. In adults, 5 milligram per kg. But of course, in children, maximum dose is 300 milligram. You don't have to just go on increasing. Ceiling dose is 300. So you must know this, the dosages that are given. Then you have to give HREZ for 2 months, and then HRE for 4 months is the standard treatment now one has to give. And then treatment duration is 6 months. Even for extrapulmonary TB, duration is the same. Principle remains the same, doses remains the same. You don't have to, change the regimen. Only you can prolong it when it is bone, joint, meningeal, or it is disseminated TB. Otherwise, standard treatment is 6 months only. And even if you think that this patient is eligible for prolonged therapy, this should be done by experts only. So better refer these patients to the expert. So, and as, if you are using regimens without isoniazid or pyrazinamide or rifampicin, then you have to prolong treatment accordingly. Quinolones, I already told you. Hepatotoxic toxicity, Dr. Prasad very beautifully explained to you. You may have 3 scenarios: jaundice, symptomatic with less than 5-fold, or asymptomatic with more than 5-fold. So you have to look for the chronic liver disease. If there is one, then you have to stop depending on the condition of the patient. If it is lethal, very sick, you may stop all, or you may start with undercover, and then reintroduce these drugs slowly, so that most of these patients usually tolerate. Pyrazinamide, out of all these anti-tubercular drugs, is the most hepatotoxic. So usually if there is a severe hepatitis, do not reintroduce pyrazinamide, and this may require prolongation or duration to 9 months here. So if there is a drug rash, stop all ATT drugs. When the rash has substantially improved, medication can be restarted individually at intervals of 2 to 3 days. During this, when you have stopped this, as Dr. Prasad was also saying, you can use quinolones or streptomycin to complete the regimen. Rifampicin is usually restarted first, and then followed by INH, ethambutol, and pyrazinamide. If rash recurs, the last drug added is stopped. That is in general, the rule for managing all drug-induced rashes. This is also called de-challenge and re-challenge. De-challenge means that you stop drug, and then after resolution of the symptoms, you reintroduce, re-challenge. If it is appearing again, that means it is definitely due to that drug. Otherwise, you may classify them as probable cases of adverse effects. So the same principle applies here. Reinstitution of treatment must take into account the bacillary load. When did this interruption happen? What was the duration? Usually, if the interruption is more than 14 days, this should not be allowed. And if it is more than 14 days, you need to restart the treatment. Greater the need to restart therapy when treatment interruptions occur earlier in the treatment, and you have to prolong treatment accordingly. So again, one of the, TB meningitis is again life-threatening disease here. Gene expert is the very sensitive test for this. This is the first test that should be done if you are suspecting meningitis, and usually you use large CSF volume, but negative expert test does not rule out TB meningitis, so you may have to do further testing. But you can start empirical therapy in case of high suspicion at the time of testing. Definitions, you must apprise yourself about the definitions being used. Pre-XDR TB is resistant to isoniazid, rifampicin, and any quinolone. Previously, then XDR TB is resistant to isoniazid, rifampicin, and any quinolones, and either bedaquiline or linezolid, like that. I don't think so. You need to burden yourself with this. Whenever you see a patient with MDR, these patients should be referred to the experts for this, because again, we need to handle this. We haven't handled drug sensitive TB very well. That is why we are having this problem of MDR TB, and 50% of the patients with MDR, they die. So it's a huge number, and we need to treat them properly, so that, because if MDR becomes more and more prevalent, then it is MDR which is going to spread in the communities. So it would be impossible to eliminate TB. So whenever you have a history of past ATT, complete or incomplete suspicious of MDR TB should be raised. History of contact with MDR TB, persistence to sputum positivity after 8 weeks of ATT, no clinical improvement, deterioration despite adequate trial of ATT for 3 months, or when there is a disseminated disease or a cavitary disease, you should suspect MDR TB and evaluate further. You have tests for this. I will not and confirm this. Don't just drug sensitive TB, you can start empirical ATT, but for MDR TB, always confirm before you put them, because it has a lot of consequences. It depends on which drugs to be used, which regimen to be used. So drug sensitivity testing is the gold standard here, so it must be used for this. I am not an expert in MDR, so you can excuse me for that, Then latent TB, I think we were all talking about. This is also very common. This is defined as an infection. This does not mean that active disease is there, but there can be a lifetime risk of reactivation of the disease up to the extent of 10% conventionally, but currently it is 4 to 6%. Incubation period of TB is typically several months to 2 years. And after that, disease is relatively infrequent. So this is immunoreactivity to TB does not necessarily indicate the presence of live bacteria. So as reactivity can persist after infection has been cleared. So when you do this, you can use this tuberculin test, TST, Mantoux test, or IGRA for that. Quantiferon gold is the test that is being very used. But interpretation of these tests is also very important. You must look at the context, in which that this test has come positive. So whenever you are looking for Mantoux test, look for induration, not erythema. Many people count erythema and they falsely label the patient as Mantoux positive. So this indicates exposure to TB, latent TB, not active disease. It can be false positive due to BCG vaccination and atypical mycobacteria. It could also be false negative due to energy. So once positive, this remains positive for lifelong. So don't repeat it. There is no need to repeat after. And you may find up to 40% of the Indian positive for Mantoux test. So again, repeating, don't use this as a test for active TB. No role of this Mantoux test in diagnosis of TB. So don't use this as diagnostic test. Always go for AFP, smear, gene expert, culture for the diagnosis of the TB. So latent TB, whenever you have these, you must, if you in our target to eliminate TB, so we also need to manage this latent TB also. So patients, especially with HIV, diabetes, malnourished, cancer, immunosuppressed patients, they need treatment, TB preventer therapy. This is called TPT, which should be given. And infants and children less than 5 years of age who are household contacts of pulmonary TB, patients on anti-TNF, dialysis, organ transplantation, these patients should be given TB preventer therapy. Then always when you have, these are the patients where you can start TPT, but if you have asymptomatic contacts of infectious TB patients, so you have to rule out active TB before you put these patients on TB preventer therapy. So there are guidelines for that you need to look at it. The chemoprophylaxis for with TPT is, we have three different regimens now I accepted. 3 HP is weekly INH and rifampicin for 3 months in people older than 2 years, or 6 months of INH monotherapy for 6 months, or 3 RH rifampicin INH for 3 months for children and adolescent aged less than 15 years. So this 3 RH is for children and adolescents aged less than 15 years. Otherwise, standard of care remains INH monotherapy for 6 months. So let's summarize. Use expert MTB Ultra or CB0 for diagnosis from all samples at all sites. It can be used. There is, if you use this Gene Expert, there is no need to repeat this AFB smear. That will save time and make the diagnosis quicker. Order AFB culture routinely with smear and expert, and give standard regimen HREZ for 2 months and HRE for 4 months. Look for diabetes and HIV in all patients with TB, and it's said the both ways. Those who are diagnosed with HIV, one should rule out or look for TB in these patients. Avoid ADA and TB PCRs. They are not expert or CB0. They are not same as expert and CB0. Use, as I said, use LBA or expert XDR for diagnosis of MDR TB. Now we have treatment available for shorter treatment available. So once again, I will repeat, do not use IGRA, quantiferon TB for diagnosis of active tuberculosis. This just positive test just indicates a latent TB and never an active TB. And always give chemoprophylaxis to contacts or for high-risk patients with latent TB. And now one more last thing. I think there was one question in the pre-test. I deliberately had put that question there because if you want to eliminate TB from the community, how do you do it unless you break the transmission of this bacilli from infected people to non-infected people? Is use of there are certain things that you can do. Is use mask. There have been studies which have shown a simple surgical mask used by both the patient as well as the healthcare provider. I think I was looking at the pre-test responses. Many of you said, it is okay if you wear N95 masks. Yes, you can be protected, but the patient will be spreading this infection to other contacts. So whereas surgical mask, if used by both patients as well as the provider, it can effectively reduce the transmission. Of course, the other environmental controls are also needed. Well-ventilated place, high ceilings, and air changes, frequent air changes that will help you in reducing the suspension of the transmission of this infection. The UV light, especially when it is from the roof, it can help, but these are all we may not have that kind of infrastructure. Considering all these environmental controls, I think the most effective, cost-effective preventive strategy is to use surgical mask for all coughing patients and for yourself, to protect yourself, because getting these infections is one of the occupational hazard that we all face. So with this, I would like to conclude. I think your answers were your queries were already answered. I just tried to recapitulate and so that take-home messages are delivered once again, and you can effectively manage this. Regarding the treatment part, we did one study way back 10-15 years ago. Different people were using different regimens. So I thought, I was in Chennai few months ago, and I saw a study report being presented that even today many of us are using different regimens, different dosages. There is no need to experiment. This is not a question of professional autonomy, that we must use standardized treatment for TB if you want to get rid of this TB, eliminate this from our this country or the world. Unless we standardize, make sure that the already the treatment is so long, 6 months is a long period. And if we continue to mishandle this, we may not have very good drugs or cheap, effective, well-tolerated drugs available. Thank you for patient listening on this afternoon. This was the last session of the second series. So we've had successful, 2 series. So that means 24 sessions. In the first series, more than around 8,000 people collectively attended. I don't know, Siddhi, how many people attended this series? Maybe
It's also around 8 to 9,000.
Oh my God. So that's a very, very good number. That is quite encouraging also. But I was looking at the pre-test and the post-test, we never bothered about the scores because our aim was just that you start attempting it, you start thinking about it. But when we looked at the number of responses for pre and post, we found that those who took pre-test did not take the post-test. So we couldn't make out. So maybe next series, third series, when we continue with it, I will request all of you, please do attempt both pre and post. So that is what it will help us in understanding whether those issues were well addressed. Although I make it a point that these points are covered during the presentation, but still we may have, either, for some reason or the other, it may not have been adequately covered. So it will help us in looking into it. I think Siddhi has already put the post-test link here and the feedback form, and there is a YouTube link also here. Please share this YouTube link. Many people, write to me personally after that we want to see the YouTube because we could not attend the session. So you can share this YouTube link in the within your groups. That will help them in covering, catching up with the sessions. Dr. K.K. Arora, thank you. Thank you for joining in. Is there anything else that you would like to say, Siddhi? Is Deepika there?
No, ma'am, she left just now.
Okay, fine. So I think next series we will announce it shortly, and keep looking for it. Meanwhile, I would request, please, all of you, please do the post-test as well. Because when I start doing the pairing, I don't find, I find half the, tests are not being done in the post-test. I'm not at all looking at the scores. Don't bother about the scores. This remains anonymous only.
Ma'am, the pre-test and post-test number is quite low, like comparatively.
Yeah, that is what I found.
The analysis. And next session, next series, same third Saturday of every month. But we need to, ma'am, discuss about the sessions.
You can also suggest topics. Last time you gave us some of the topics. We have noted all those topics. Please feel free if you think that you need guidance from experts on anything which has not been covered. We can try and do this. But I feel those sessions which have already been done, YouTube recording is already available. So there's no point in repeating those sessions, but certainly new topics which have not yet been covered, we'll try and do this. I think today we finished on time.
Yes, ma'am.
It was the last session, so
there's this feedback link in the chat box. Please give your feedback and also suggest some topics for the next series.
Epilepsy was done in this series itself. I think it was the second or the third session. Oh, it was a previous series.
Yes, ma'am, it was the previous series.
Siddhi, one thing you can do is, if you have YouTube, you can tell me for sessions for which YouTube is recording is available. And if suppose for some reason YouTube recording is not available, we may think of doing that again.
Ma'am, we have a YouTube recording for all the 24 sessions.
Yes, mental health. I think that is another issue. It is because it is very common, and many of us feel very much scared of handling these patients. But this is very common. So certainly we will do this this time. You can put the post-test link again.
Yes, ma'am. We have participants from the sub-center level. If they want any specific topic to be taken up, even they can suggest like from the primary level or from the sub-center point of view.
Please, yeah. Please do give feedback also. Very few of you are giving feedback. That helps you in assessing our performance. Thank you, Siddhi, for providing all the help backend
Pleasure, ma'am.
for all these sessions and issuing certificate, handling those queries from the participants. We keep bothering, some of them keep writing to me, we haven't got the certificate.
Thank you, ma'am.
You can also, put that email ID here where they should
Yes,
be
ma'am.
writing. Yeah. Thank you, all of you. Once again, to all of you, without your active participation, we could not have completed this series, because the numbers and the enthusiasm that you showed by asking questions, it was a great motivation for us to continue this. So I once again, on behalf of NHSRC, DSPRUD, would like to thank all of you. See you in the series 3 next time. Thank you.
Thank you, ma'am. And we have got a nice suggestion for monkeypox.
See, if you don't, if we, this will keep happening, maybe we can do one session on antibiotics.
Yes, ma'am.
Nature has always remained in control. So this is the time, because we temper with the nature too much these days.
Yes, ma'am. Okay. Thank you, ma'am, for all your support and guiding us, taking lead every time for arranging the resource person. Rest, I'll connect to you, ma'am, personally, and we can discuss about the sessions.
Yes, you can leave. Those who have done both post-test and feedback can leave.
Those who have not received last session's certificate can write to us on spg.webinar@nhsrcindia.org. हाँ ये तो डाल दीजिए. You will receive your certificates after 10 days.